such an honor to be here today in front of you guys. I see some of my heroes in this crowd. I see some people that I've learned fundamental things that have changed my practice and concepts about how cavities work and how to treat caries. If that weren't enough, I get to share the stage with these guys. So Doug asked me to give a talk on silver diamine fluoride at this presentation, and I don't think anybody on this panel here does what they're told. So instead, we're all going to give a presentation. It's going to be a little bit of a round robin or tag team, and each of us has different parts to contribute. I think it's going to be pretty fun. And we did a little slice of this at UOP in December, and this is so much more. These guys on the stage and one other gentleman named MacIntyre and I think on average, since about a year ago, send at least 12 emails to each other. So I think I talked to these guys more than I talked to my wife, maybe. I don't know what we email about. We find some things, and Jason will find a new paper, Steve will find a new paper, Doug we'll find some student that asks a question. John will see 80 patients in a day and figure out some new way of doing something. So we've put more work into this presentation than any presentation I've been involved with before. So I hope it satisfies your curiosity about this material that we've all gotten in our hands somewhat recently. I hope you find it entertaining and engaging. And I hope that everyone comes out with at least one question. How the hell did you say that? Or what do you mean? Or maybe you have an idea to bring it further forward. So as Brian mentioned, we're not just talking about silver diamine fluoride, but how to incorporate that into some other fun things that we think will really bring dentistry forward. And in our hands, each of us has brought dentistry forward. So disclosures, none of us has any financial interest in any silver diamine fluoride product, or as far as I know, any of the products that we're discussing today. As you see, Steve has a product that's not available in the US that's silver nitrate and fluoride varnish. Some of us have been paid to speak on topics like this before from various dental organizations, and that's our disclosure. So here's our outline. So if you start with the idea of silver diamine fluoride, this is the cascade of topics that becomes relevant. Glass ionomer cement, Doug's going to talk about. Partial caries excavation, Doug's also going to talk about. John and Steve are both going to talk about SMART. And then Steve and Jason are both going to talk about the economic model, and then we're going to open for questions. At the beginning, we're going to go through the science of silver diamine fluoride. And that really sprang out from some of the work that I got to do helping with a committee in the dental school at UCSF. John Featherstone asked me to be involved in the Paradigm Shift Committee subcommittee on evaluating silvers about almost 2 years ago now. And in 3 meetings, we had put together a guidelines and protocol, full literature review. And a couple months later, we started using silver diamine fluoride in the pediatric dentistry residency, in the general practice residency, and a couple months later in the dental school. So as far as I know, that was when silver diamine fluoride use started in dental schools, was October of last year, and we rolled it out fully. So a little bit about me. I'm a practicing pediatric dentist. I'm a practicing biochemist, and I have a passion for laboratory research, really playing with big data and public health. And nobody knows what to do with that. So I've been trying to put it together. I'm in the biochemistry department at UC San Francisco, which is outside the dental school, which has enabled me to be free to kind of do whatever the hell I want to do. So that's why I'm here. And it's been great. This is the 42nd silver diamine fluoride presentation that I've given in the last 3 months. So hopefully, what that has done is it's made me and my friends here kind of a nexus for information on this topic. So hopefully what we have to share will be useful for you. And I think it will, because most of what I've learned is from other people in these presentations and so on. So on to the science. I can never start science without a clinical context. So this is one of my patients. Sorry, the panels are supposed to reveal more slowly. So when I first got out of residency, I saw this kiddo named Jaden, and his mom has asked that I use his first name instead of not mentioning his name because of how important he is to her. He has a laundry list of medical ailments, no specific overarching diagnosis. But, he was almost 4 years old then, and now he's over 7. And you name it, he's got GI abnormalities, brain anatomy abnormalities, he still has not said a word, doesn't really get out of his wheelchair too well, and so on, seizures, you name it, heart disorder. So I saw him in the practice that I had joined to do 1 day a week outside the school, and saw that he had been through general anesthesia a year before for treatment of his caries through drill and fill dentistry. They did 4 standstill crowns, 8 composite restorations, and by the time I got to him a year later, all the 8 composites had failed, and he had 9 new lesions. So when he was about 3, he had 12 lesions. When he was about 4, he had 17 lesions. And I told his mom, said, hey, we're going to take him back to the operating room and fix up his teeth. And she looked at me and said, no way. Long story short, I talked to the pediatric anesthesiologist. She said, no way. Turned out he had almost died from an unrelated procedure in anesthesia a month prior due to the anesthesia because his lungs are so weak. So I had to figure out something else. Well, luckily, I read a paper that Steve Duffin wrote, published in 2012, about using silver nitrate and fluoride varnish to arrest caries. And knowing some of the history of how silver nitrate and fluoride has gotten into this country, I knew that it was to stimulate the silver nitrate and the fluoride varnish were really to stimulate the silver diamine fluoride for the action of the silver and fluoride together. So I got some silver nitrate, got it back, started putting it on. I put it on every 3 months, the lesions only. And in the lower left, all those black spots, basically all of his cavities stopped. Basically, not all of them. One of them kept growing. You probably can't see the resolution there, but oh yeah, you can. There's a little white dot pointer. Awesome, thank you, Jason. Little white dot on that upper first left primary molar. Right in the middle of that lesion, it was soft and kept growing. So 1 out of 17 lesions kept growing by 1.5 years. I kept putting it on, silver and fluoride, kept putting it on. And so 1.5 years, because that was growing, and his mom said she thought something was bothering him on the top, which probably was his molars coming in behind there, but I couldn't know because he doesn't speak. I did some Hall crowns, put some Hall crowns on his upper molars. So I just saw him again about 3 weeks ago now, and no new lesions. So he went from 12 lesions at 3, 17 lesions at 4, and now he's turned 7, and he hasn't had a new lesion since. We did have to treat 1 lesion. I chose to treat the other primary molars because they're going to be there for a long time. And as you can see, these lower incisors exfoliated. So yeah, there were some stains. I didn't care, he didn't care, Mom didn't care. And this tooth is about to fall out as well. You can see here. But what's cool is he's actually cured his lesions, so they're not arrested, they've ground up because he has such attrition. It's kind of cool. And so my story with silver diamine fluoride, technically I had used it a few times in 2008, but basically started with Jaden. And I used it on my next special needs patient, my next really young patient, and all of these one-off patients that I really didn't have a good answer for. Operative care wasn't going to work. The lesions were too bad. And then I got to the point where I started saying, don't normal kids deserve this too? What about normal adults? And so that's the journey that we've been on. So from that story, what I'd like you to see is that a couple parts about this. 1, it's really easy to do. 2, it's going to stain the crap out of the lesions. 3, it stops most lesions, not 100%. Stops most lesions. Pretty typical that one will keep growing from my experience since. Done this on hundreds of kids now. And 4, that we get this indirect prevention. So I only put it on the lesions, but we didn't get any new lesions anywhere else in the mouth. And I see that over and over again. Sometimes kids still get lesions, but they're much fewer than they would have otherwise. So we'll talk about some of the data behind that. So hopefully that frames things for you guys. And so what is this stuff? Silver diamine fluoride. Silver kills bugs. Fluoride at high concentration also kills bugs, and as we know, it's a remineralizing agent. The ammonia basically keeps this stuff stable in solution. So it keeps it nice and stable. And what does it do? Like I just told you about Jaden, it stops lesions. We're calling that arrest. It prevents caries both directly and indirectly, so a lot of people will use this on newly erupted first molars or newly erupted root surfaces in high-risk patients. And indirectly, meaning that if you only apply it to lesions, the chances of that patient getting a new lesion on an untreated surface is much lower. And that single factor is the most exciting thing about this for me. The most exciting thing about silver diamine fluoride. And it decreases hypersensitivity, and that's FDA clearance. So where did this come from? I'm going to do this very briefly, but silver nitrate's been around for a very long time. The earliest publication in the United States on silver nitrate for caries arrest that we found is 1846. There were publications, a lot of them in the 50s, a lot of them in the 20s, some in the 70s. And somehow that digital divide, once the internet started, we stopped going to the library and looking at books. And so over my 2-week vacation, I was actually reading a whole bunch of articles that Steve Duffin found in the ADA library before it closed about silver nitrate. So anyhow, this was used for a long time to arrest caries, and it wasn't perfect. Silver fluoride has been used in Japan for a very long time in some other island countries. And it was known that it blackened teeth. People did this intentionally. If you see that picture on the bottom, the blackening of the teeth was seen to be beautiful. You know, in those days they had black, and these days we have plain. Go forward. Somewhere around the 1960s, Japan, their report to the FDA, approved the addition of ammonia to make silver diamine fluoride, and it's been monitored ever since there. And over the decades since, it's been cleared for use in Australia, Brazil, Argentina, Cuba, and China, and now, of course, the United States. And so, as probably everybody in this room knows, it became available late April last year. It was cleared by the FDA a year before that. And I think that's, it's an interesting part of the story to me, is that it was really a massive public health clinic in Oregon and a dental school professor that got this through the FDA. And so when the FDA finally said, okay, they didn't have the bottles ready, they weren't able to sell. When you get a medical device or a drug through the FDA, you have a big company resting on all of the work that's been done to get that there, and those you start selling immediately. So I think it's telling about the long journey and the non-standard journey that we've had to do an end around to get this thing that works so well into our hands in the United States. So that's important to me. The FDA clearance, just like fluoride varnish, is hypersensitivity. It is not cleared by the FDA for use on cavities. So it's the same as fluoride varnish, that we use it off-label to prevent cavities. And any clinician, any prescribing clinician can do that. And it's important to understand. So that was a lot of background. What is this? Where's it from? Where's it at now? To my knowledge, an application just went into the FDA this last week to try to get a drug approval for the disease indication of caries. And so that's an ongoing approach as far as I know. Now we're going to get into the data. And this is a lot. I don't mean to scare you away with graphs, but I think it's important. I've heard all sorts of stories along my journey in education, and I'm technically still in school. So I've been in school for 32 years now, I think. And I hear stories, and then I look at the data, and the data tell a different story than the stories that I hear. So we published this in the CDA journal. Anybody in the world can get that for free. And I invite you to really carefully look at the data yourself. Don't just trust what I say. Look and make your own decisions about what you think, because that's what I found to be useful. That said, these are all the published randomized clinical trials that lasted at least a year that have been published in English in children for stopping caries. And each panel is a different study. Some of the details are on the left. You can see there's 370 kids in this one and 840 kids in that one. And the timeline is all the same. So when I put this together, I wanted everything to be on the same timeline so we could learn about how frequently we have to use this, do we have to repeat use, etc. The red, colors aren't coming perfectly pretty. Hopefully you can see the red. It's a little bit black. Is twice per year. The black is once per year. And stuff towards the bottom is once and then never again. And so just to focus in on those that look at how often we have to do it, the red is twice per year, the black is once per year, and then the stuff at the bottom is once and then never again. And I don't think you need a PhD in epidemiology to see that if you keep doing it, more and more lesions start arresting. And if you do it once, you get an initial effect. Almost 50% of cavities are stopped at 6 months. And if you don't do it again, they become active. So this is what we looked at at UCSF, is all these data to try to put together a protocol. And certainly the basis is this stuff works. So the idea here is if the bars go up, more lesions are arrested. If the bar, you don't see a bar, which you see a bar everywhere, then no lesions stop. So the higher the bars are, the more the cavities are stopped. And so it seems to work, so we decided to use it. One of these studies looked at excavating prior to putting silver diamine fluoride on. There was no benefit. One of them looked at fluoride varnish 4 times per year versus silver fluoride once per year, and silver fluoride worked better. And there's a lot of heterogeneity. This was a different percentage, but they got a much lower result. And so, why? Well, certainly one can think about using Cambra to try to figure out why. What are the individual factors or community factors that are different between this group and these other groups? These studies were carried out by the same folks. Anyhow, we saw that it worked. We developed a protocol of twice per year or more often, depending on caries risk and severity, to arrest caries. These are the studies on prevention in kids with silver diamine fluoride. Same layout, it goes out to 3 years, and 0% would mean that compared to the control groups, all these studies had a control or placebo group. 0% would mean that they got just as many new lesions as the control group, and 100% would mean that none of the kids got any new lesions. So if the bar went up to the top, that would be great. Now these 2 studies are, I think, the most important 2 studies on silver diamine fluoride. I've actually already shown you them. These were arrest studies, where they looked at untreated surfaces. Remember I said untreated surfaces before? So they only applied silver diamine fluoride to lesions. They applied it to all the lesions. And then they looked throughout the rest of the mouth over the next 3 years and 2.5 years at how many new lesions started, and 70% less. Now, full mouth restorations doesn't do that. Operating room dentistry doesn't work anywhere close to that. Some lesions were still active, which I showed you here. Sorry. Here, some lesions were still active. It was not 100% arrest, but it made this enormous impact here on prevention throughout the rest of the mouth. This is the reason why I'm most excited about silver diamine fluoride. If you compare it to fluoride varnish throughout the mouth, 4 times per year, this did better. Once per year, silver fluoride, 4 times per year, fluoride varnish. 70% arrest versus about 70% prevention versus about 40% prevention. Pretty cool stuff. So that is what I'm most excited about. Now you can tune out. But there's also studies in older adults that have been published that have been at least a year. And so this is kind of the same format. The arrest is at the top, prevention is at the bottom. The orange and black studies, go Giants. Can I get a go Giants in the prevention and arrest, that's the same study. And so we're all scratching our heads about why those numbers are so low, especially all 3 of these studies were carried out by the same team in Hong Kong. Now one was out in the community, one was in Hong Kong, one was rural. Point being that it can work, doesn't always work, we need to learn more. And it works better than anything else that we have. So for prevention, these were folks that lived in a nursing home. Silver fluoride once per year to newly exposed root surfaces in older adults, compared to 4 times per year fluoride varnish or 4 times per year chlorhexidine varnish, and then compared to placebo. Once per year, silver diamine fluoride did better. So as a group, we said, well, okay, if we can do 4 times per year of this other stuff, why not do this 2, 3, 4 times per year? Maybe that's right, maybe it's not. to summarize these clinical trials, in those studies, the silver fluoride groups contained over 1,800 patients. Nobody died. Nobody had a severe reaction. People, their gingiva turned a little white for 2 days and it went away. So from that, we think that this is pretty safe. 9 were on cardiac arrest, and you get about 90% arrest with twice per year application, at least in children. So for my really high-risk kids, my extreme-risk kids, I do more than that. I watch a little more closely because not every lesion stops. And it doesn't get to that 90% until about 1.5 to 2 years. That's different than anything we've had in dentistry before. For prevention, again, there's this massive indirect prevention, but probably indirect prevention because I don't think we have a term for it. And it outperforms anything that is compared to. Again, silver fluoride once per year compared to fluoride varnish 4 times per year, both in kids and older adults, did better. So that's pretty exciting. Now, I don't pretend that you're going to understand that you're going to see any of the data or details on this slide. This was just published, I think, a week or 2 ago, and so we had to throw it in. This is an actual formal meta-analysis of all of the clinical trials on silver diamond fluoride that the main group that's been doing these clinical trials can find. So the group's in Hong Kong, #1 dental school in the world this year, I understand. They like to remind me of that. And I can see why they chunk out clinical trials and do great things. So if you've never seen a forest plot before, that's what this is called. And I think about it as each individual study is summarized as like one tree in the forest. And then this little diamond, and then the diamond down here tries to give you the forest view. What's the overall view of how well this stuff works? And so each different forest plot is on a different scale depending on whether it's odds ratio or arrest rate or whatever it is. This is for arrest rate, where if we're at 0, that would mean no lesions were stopped. If we're at 1, it would be 100% of lesions are stopped. And all these different trials, and they found trials in Portuguese and Chinese and Japanese and all, 81%, despite how often they put it on, they put it on once and never again, or 2, all of the studies, their summary is 80% of lesions stopped with silver diamond fluoride. So first, that tells me that's better than anything else that we've had as a topical medicine for caries. Second, it tells me it's not 100%. I've heard a lot of talking about bias, that the studies are very biased. And so also in this report, they looked at the bias of all these different studies and went through and said, okay, what are the biases? What are the weaknesses? If it's green, it's good. If it's red, it's bad. And what you see is that, the top half of pretty much good stuff there. And the problem with the clinical trials, the main problem, I think there's 2. One of them they didn't address here. One of them is if you put silver diamine fluoride on a lesion, a week later it's going to be black. And so if you do a clinical trial where you put water on one lesion and silver diamine fluoride on the other lesion, whether the lesion is arrested fully or not, there's going to be some black in that lesion. And so it becomes really obvious which kids were treated with which. And so that's been the big question about the trial on silver diamine fluoride. That said, those of us that have been using it know that if the lesion is still active, there's a white spot somewhere in there. There's a yellow, soft, sticky white spot in the middle. So it also seems kind of obvious to us. The other thing is that as far as I know, none of these clinical trials have used radiographs. It's all look and feel with basically with a perioprobe. And so no radiographs, so we're trying to do those. Okay, last study I'm going to talk about. As far as I know, this is the first complete randomized clinical trial on silver diamine fluoride in the United States. It was a short one and an important one. Actually, I think the woman who really did the bulk of the work is in the room, Sherry Ludwig. Congratulations. Woohoo! Yeah. And so this was, in my view, this adds a mechanistic understanding in ways that we haven't had before from a 2-week perspective, and mainly it was a safety study in my humble estimation. So they took kids at 3 different head starts that were 3 to 5 years old, treated them with silver diamine fluoride or clear solution. It was randomized, everybody's blinded, and then called the parents within the next 48 hours and had an intense questionnaire about how the kids were doing, redness, blackness, pain, nausea, all those things. And then saw the kids again 2 weeks later to also look at how they were doing and look at the lesions. And so when you have 9 randomized clinical trials, one of the things that the FDA wants is a more close look at safety. And so to me, this was a big safety study. And so in the treatment group, there was one kid that had a flu afterwards. There was one kid that had nausea afterwards. There was one kid that had a little bit of redness around the mouth. And there was one kid that had a black spot that looked like an electrical burn but did not hurt. Now, if anybody's used silver or anything, you know, amalgam of when we're hand mixing and silver nitrate, it has a black dot. That is a side effect. If you get it on the skin, you'll see a little black dot. And it didn't hurt. And then the other group, 2 of the kids had diarrhea, tummy ache, toothache, diarrhea. So basically, there was no difference in safety when they looked at it really closely. And at 2 weeks, 72% of the lesions were arrested in the treatment group. Now, remember back to the slides I showed you earlier, it was less than 50% at 6 months. And so what that tells us is we're getting a big initial effect, about 70% after 2 weeks, that goes away with time. So maybe that could inform our protocols. And that's one of the things I learned also from Steve Duffin, is to do maybe 3 treatments within a few weeks. He does 3 in 3 weeks, I do 3 in a month. And these data support that. Question?
Yes, we're talking about the adverse effect and the effect of interventions on us. Why didn't put the number needed of treat and number needed of harm would be more effective understanding how many you treated? And
so the question is, why didn't we use number needed to treat? And I guess the short answer is that the trial was finished like a month or 2 ago. So that'll be done.
What I'm saying, did you see any other?
Hold on 1 second. Hold on 1 second.
No, did you see any other study what has been addressing the number of?
No, number needed to treat.
Yeah, because this is will let us know, how many you need to treat to prevent.
Yeah, from a policy perspective. Yeah. We can look that up afterwards. Actually, I don't know. And you guys have a number needed to treat for? Yeah, I haven't focused on that. It's a good question. It's important. That'd be fun to see. So it's the mechanism, a little bit more science. We're going to briefly go over this. And if you guys have questions and are interested in this, we can talk more later. How does it work? So like we said earlier, silver kills bugs. But it doesn't just do that. It reacts with the enamel and makes the enamel more resilient to acid dissolution. It reacts with the protein in the dentin and does the same. It coagulates the proteins. Fluoride, we know fluoride. It makes the dentin enamel more resilient. It promotes remineralization. And this stuff occludes the dentinal tubules and it penetrates further into dentin than anything else that I know about. So it gets down there and then it stays. And that, I think, is a really important point. It has sustainability. So in terms of the antimicrobial effects, this slide is my favorite. They tried out a bunch of different things and had dentin slices that they had inoculated with strep mutans and friends, and then treated with a bunch of different stuff. The green means the bacteria are alive, and the red means they're dead, and this is only one where it was red all the way down to the bottom. They kept it bathing in the bugs. And what you see is that if you keep it bathing in the bugs, you do get a little bit of bugs growing back in at the top, not at the bottom. And it turns out that silver stays in that lesion and kills the bugs that are trying to get back down in. So these guys probably just got there recently trying to find their way back in. So because I see those green bugs there up at the top of the silver fluoride treated lesion, that means to me that I need something else also. I need a patient to improve their diet, maybe hygiene, maybe to cover this, maybe to keep placing silver fluoride, whatever the solution is. And penetration, according to the older data, we've seen about 200 to 300 microns of very certain penetration. We'll get back to this earlier. And I've been looking at this. So this is a tooth split in half that wasn't even cavitated, but you can see that the lesion went all the way down to the pole. It's kind of fun. And one of the sites I treated with silver fluoride and then rinsed it off after a minute, sat overnight, looked under the microscope the next day, and well, you can see it went way further than 200 to 300 microns. It went millimeters and went all the way down to the pulp where the affected dentin is. And that's in a dry tooth. Lots of problems with that. Open question of whether that's relevant, but it can go deep. Same thing here. It was actually a non-cavitated lesion that I'm learning. Dr. Felixson's been teaching me how to prepare teeth and section them and all that, and I broke this tooth, but you can see the silver penetrating way further than any vestige of the lesion. And looking back into the silver nitrate literature, they knew this back in the 1950s, that it penetrates very deeply. We've also done a little bit with something called optical coherence tomography, which is becoming more popular for looking at plaque and gingivitis and early enamel lesions. And the idea there is that the light can penetrate when the tooth is weakened, and then it can't penetrate as deeply if the tooth is stronger. So they use it to measure the effect of remineralizing lesions. And so on the left is before, and you're seeing that red kind of diving down a millimeter or two into the tooth where there's demineralization. I should orient you. These are the cusp tips, and then that's the groove right there. So we're looking at a cross section where the red is diving down, and then we treat it with silver fluoride and rinse off, look at 24 hours later, and it's like plated silver. And it was white, it wasn't black. It's like plated silver on that enamel that really remineralized and strengthened the tooth. So we're looking more into how well this stuff penetrates and at what layers does it do. But it seems to be pretty deep into the tooth and blocking things pretty well. So that's all the science unless you want more, and now back to sort of clinical relevance. When would you use this stuff? So going back to the UCSF committee, this is, I think, our biggest deliverable, is when would you use it? And so at the caries risk, any extreme caries risk patient, we know they're going to keep getting lesions no matter what we do. So give this a try, it's right for the patient. And we included severe early childhood caries in that group because 70% of kids that go into the operating room get new lesions within a year.
Is this also pediatric indications or are you talking adults?
This is adults, this is all humans. Great question, thank you. Yeah, this was for rolling it out in the dental school, really. So we wanted to give the dental students something, and the professors, something to grasp onto their reality. And so behavioral medical management challenges, that is anyone with Parkinson's disease who has movement disorders, and similarly, phobic children, or what they call pre-cooperative kids, kids like Jaden that have medical complexity, all of them. And then John wrote, and some dogs, not just humans, some dogs that have been treated with silver fluoride. We got to report with that.
Steve and I treat our dogs.
I have my dog actually broke one of his cusps, and I'm a molder.
Yeah.
So you're saying it's safer than xylitol?
Or eye drops.
Dogs are still alive, right? They're good? Yeah. So the third one is a little fun. I'm glad that we got this through a bunch of academicians and educators. It's more lesions than treatable at one visit. Now, if anybody's ever stepped foot in a dental school, you know that we get people coming in, patients with 20 lesions throughout their mouths. And then you know that dental student, that third-year dental student, is going to be able to treat maybe 1.5 a day. So we said, all right, well, if they have 20 lesions, let's put this on all their lesions at that first visit, and then maybe again when they come in for the treatment visit, and then maybe again after that, and however often they come in. And as best as we can, freeze the lesions in place, and then let the clinician and the patient figure out which ones really actually need to be treated surgically. But start off by trying to treat the disease by killing the bugs and strengthening the tooth. And then go through and see what needs to be restored. Difficult to treat lesions, so caries lesions in furcations and on newly erupted wisdom teeth. I always see they're already weak and caries are starting there. Things that are hard to treat, the edge of a 6-unit bridge, the margin on the distal lingual of the canine that I always see, and then patients without access to care. This is a big one for a lot of us that there's these medical missions where folks are going and doing resin sealants and then never going back. Or composite fillings and then never going back. This, when it stops working, it doesn't do any harm. So it seems like a good solution, and it's very quick and inexpensive. How do you use it? So we have a UCSF protocol that you can read about, and I'm going to simplify it by saying dry and apply, and then say bye. Thanks. So you have a lesion that you can see, and you dry it, and that's been, we have learned, a major part of the protocol is that whatever you can do to dry it, air. If you really can't do air, then cotton. And then put this stuff on. And we have found that protecting the reaction of that silver fluoride with the lesion for at least a minute, if not longer, really benefits the effectiveness. And so some people, if you have a healthy adult who's fine to sit for 3 minutes, great. If you have a squirming 2-year-old, like I often see, I've started putting varnish after I put the silver fluoride and varnish afterwards. It just seems to increase the effectiveness a little bit. Everybody's doing slightly different things. Tray setup, you can see this is really complicated, lots of expensive equipment here. Air, bottle, plastic half dish. It turns out that there is a reaction with glass that's slow, it takes a few days, but plastic half dish. And then, like I said, we've been using fluoride varnish over the top. But you can use any varnish or Vaseline if you like, or not. Staining. This stuff stains. I show parents these pictures all the time. And it shows that the before and after, that you get, the lesion turns black, the healthy part of the tooth really doesn't. And I show the dental students the stuff in the bottom, because it takes about a week for the stain to really show up. And this was very carefully placed. If you see there's another lesion on the tooth next door on the 29th Street, 28 was not. And you see that that lesion didn't stain because they placed it really carefully. When we started with the dental students, they started placing it everywhere, and we saw the composite margin staining. Patients didn't like that. And so, if you're careful, it only stains the lesions, and it may also stain margins of restorations if you get it on there. Okay. Like I said earlier, there's been no published studies that I know of, that we know of, including x-rays. So I've been using silver fluoride for about 3 years, a little over 3 years in our practice. And so we have about 300 kids that we've used this on now, multiple times, not including just once waiting for OR or whatever. And so I went through, most of the kids we do this on, we can't take x-rays, because it's one of the reasons that they were considering the silver fluoride. And so I looked through and found as many as I could of kids that we had x-rays before silver fluoride, and then after we started the silver fluoride, and at least a year. And so we're working on putting this together into a publication, but this is a very typical result that I'm going to show you in the next 4 slides. And so we're going to go by quadrant of the mouth or sextant or whatever. And so the kid started at 3 years, 10 months, was referred from a community clinic for sedation or operating room care. Long story short, couldn't do something, so we started silver nitrate fluoride varnish. April last year, we switched over to silver nitrate fluoride. And the lesions on the lower incisors, interproximal, did not grow across over 2 years and 6 treatments. They didn't grow. The uppers, we disked to open up the interproximals also, and did silver nitrate fluoride varnish, and then silver nitrate fluoride, and they did not grow, no pain, no abscess. I keep looking at these x-rays, but really there's no abscess, and now the teeth are exfoliated, the upper incisors, so we're good. Now for the posteriors, what we see is a little bit different. And the posterior interproximals, from the protocol that we were using, just drying the embrasure and putting the silver fluoride on the embrasure, we see lesions keep growing sometimes. So you can see tooth S here, that lesion keeps growing. So one of my colleagues saw the kid at this visit, at the middle visit, and decided to place some restorations. And they did so. And then on the other side, for sure, sorry, this is tooth S, but lower first primary molar. This lesion definitely grew. And so they decided to place some crowns, and for whatever reason, they did crowns in this tooth as well.
So out of curiosity, when the clinician went to restore these posterior teeth, is there any report on clinically what they observed of the appearance and the texture of the dentin?
That's a great question. We've had some heterogeneity around that. So in particular for this kind of lesion that started off as, right around the DDJ, first third of the dentin, and then be more substantial in size. sometimes what we see is that the top layer is firm, and there will be a soft spot somewhere in there, and that leads to a bigger, soft area, kind of like a blown out version molar that you see in permanent teeth sometimes. Yep. And if they were cavitated, we don't see this. So this is specific to lesions that the marginal ridge is intact. And what we think is that it's just not getting there. And so Jason Hirsch developed a technique that turned out GB Black had a very similar technique, so I'll talk about a little later, to get it there. We just started, I don't have radiographic evidence about that. Just to sum up this last point, no new lesions. Yeah, no new lesions for this kid, even the other posterior neuroproximals.
When I've treated adults with silver nitrate, I often see on follow-up that I can actually see the silver lining or a silver haze on the interproximal where I've treated.
Interesting. How are you getting it there? How do you apply it?
Well, sometimes it's direct. I have a lot of older patients, perio, so I can actually get in there directly. And then I've been trying this flossing technique.
The super floss, yeah. Yeah, wonderful. Yeah, so this is, I just want, go ahead.
Just, is there any determination about how the prevention is occurring? Is there an assumption that it's getting into the saliva?
Okay.
You want to join a 12 email per day email? There's postulation, we're starting to test it. These guys have been collecting saliva samples. Boom. And sending them to us in the lab. Surprise! And we're starting to test that. We're doing oral microbiome studies. I think in the next year you can see a flurry of oral microbiome where we're looking not just at streptocans, but all the bugs in the mouth. We've been doing some of that, and the answer is that there's no data yet. From what I think there was one patient that we got data back from, we couldn't find a lot of silver in the saliva. But we're doing more patients.
Jeremy, along the lines of prevention, do you see that SDF will actually displace the more traditional resin sealants on an efficacy basis and on an economic basis?
Ultimately, it's all cost effectiveness for treatment. Absolutely. I could treat 12 kids with silver nitrate fluoride as a preventive on their first molars, and the amount of time that it would take me to put resin sealants with a good assistant in a good practice. And, yep. And it doesn't stain healthy animals. Yep.
Do you do this on primary molars?
The question is, can you do this on primary molars? Sure. I think the one part is that it's 8% ammonia, it's 5% fluoride. Silver is extremely safe. Those things that, ammonia is caustic, fluoride has its effects. So we want to limit the total dosage. So I do get emails asking, can I just slather this everywhere? I think the answer to that is no. High-risk surfaces. So if you have a high-risk patient, put it on the occlusals of their molars. If that's a kid or an adult. If you're really, you see the older three siblings, already been to the OR.
Yeah.
Yes. Go ahead. And, use judiciously.
For those that, for those with really poor oral hygiene, I'm real passionate about the mental health community, and they have a difficult time with their toothbrushing and that type of thing. Have you had any experience with that, and is there success with it?
Steve is going to show a really nice case later on, and I'll table that until he talks about the case because it's profound.
Hey, Jeremy.
Yeah.
This is Mike Triplett.
Hey, Mike.
When we did the work on the SDF, the FDA required us to treat 28 teeth in a bunch of people and then do blood urine and saliva. And I did to see what the content was. And 90% of the silver was absorbed into the tooth, and only 10% was actually treated.
Yeah. So there's a pharmacokinetic study in adults. They did just do 25-year-olds, mid-40s. And there was a big jump in the silver in the blood. Basically no jump outside of the normal range for fluoride, which was pretty impressive. And so that was enough to treat 3 lesions. And the CDC and the EPA have cleared silver for having no negative physiologic effects. So that seemed fine.
So Jeremy, this is Brian, I have a question. Are we throwing you off by hitting you with questions right now? I see Doug nodding his head, so we will have time for questions, but I love the
I
fact
was
that
hoping the moderator would step in.
I was stepping in and handing the microphone off, and then I didn't know how to get up there to say, should I be doing this? So, all right.
Cool. So I am wrapping up the silver fluoride component, so I did want to say that, I did want to take some of those great questions and keep them coming right now. Keep coming. This is just a brief, this is cleared as a cavity varnish for hypersensitivity. And so, drill and fill dentists, a lot of our concern is about post-op hypersensitivity and about causing necrosis, causing irreversible pulpitis and necrosis. And so there's a young man named Michael Griffith who's been in practice for about 50 years, I think, in San Francisco. And he's been using silver fluoride for a little over 3 years. And he treats primarily older adults. And so he has these lesions, the before is at the bottom. He has these lesions that he's pretty darn sure in these root caries in older adults are going to be in the pulp. And so he has a case series, there's no controls. He has this sort of historic controls that in these folks he would end up doing root canals in 90% of them. And so based on his 90% prediction metric, he included 58 premolars or molars in older adults that he used this basically as an indirect pulp cap to try to prevent a need for a root canal. And so far he's had at least 58 that are open and 2 of them abscessed, whereas this is his 90% group. So it's not a well-controlled trial, and it is working for some clinicians that at the bottom of their restoration, where they really don't want to take out anymore, they're getting good success in high-risk patients. So, pro tips. Dr. Steve Duffin shared with us 3 times in 2 weeks. I found patients and parents were much more amenable if I said 3 times in a month, and they really follow that. They come back for him, he must be a nice surgeon. Cover immediately with varnish, cover something. I compared my clinic data to his clinic's data. He gets a higher arrest rate and a no need for treatment rate, no need for surgical treatment rate. I started covering with varnish or Vaseline. Light cure to precipitate. This goes back to GV Black. If anybody's ever cut a class 1, class 2, class 3, class 4, class 5 restoration, if you read the rest of the book, he talks about silver nitrate quite a few times. And he would actually take kids outside or adults outside and use a mirror to reflect the light of the sun to precipitate this in place. It's pretty cool. And so light cure can do the same thing. Turns everything black. In an attempt to get this stuff into the interproximal, Dr. Jason Hirsch came up with the idea of using superfloss. So his video's online, you can read about it in a million places, but you put it in the superfloss, put a drop directly onto the superfloss, and hold it in place for a minute. Pull it into place for a minute. And then you can also use ortho separators. So we got a guy named Neil Satpu who has been using ortho separators to open up the contact and place it directly. And my last bit from this is to talk about caries balance and Cambra. And when I have 15 seconds to explain Cambra, what I say is that we know about caries risk, that we can predict who's going to get more cavities and who's not. But for the folks that are not, Cambra means doing less for those folks. Or for the folks that are more likely to get new lesions, means doing more for them. So the question about how does this relate to Cambra, I think the first is that it kind of titrates perfectly. The more lesions a patient has, the more of this you're putting it on. But also frequency. So higher risk should denote a higher dosage, and the way that we put that is a higher application frequency. So my high-risk kids can come back 4 times a year instead of 2 times a year. If it's really bad, I want to see them until I'm sure that the lesions are stopped. Can be used for prevention by risk, like you were talking about. We're supposed to be doing sealants by risk. Everybody just does them if they do them. But you can do it by risk, and you can do that frequency by risk. It's one of many options for treating and preventing caries. There are other things. This is not the only tool or tool belt for any of us. It should be used as a part of an integrated strategy to lower risk factors and raise protective factors. And also, a really cool thing, this is really pointed out by Nate Kaufman, is that changes to the lesion following SDF treatment, i.e. hardening and staining, enable the clinicians to monitor the success of the treatment plan. So if the lesions are still active and your treatment plan's not working, if it didn't turn black completely all throughout, then you're not doing enough, and you need to think about the other tools in your tool belt. So, we've been through this take home, over 90% arrest in kids when used twice per year, powerful indirect prevention, drive before use, safe, stains the crap out of everything. So I'm going to turn this over to Dr. Doug Young.
Jeremy, we have one question right here, and oh my gosh, hands are going up like crazy. I don't know what to do, but I'm gonna let her answer. I'm gonna let her ask her question.
Let's do one question for now, and then maybe table the rest for later. You guys okay with that? Unless somebody really feels like it needs to be done.
I'm the moderator, and we're all okay with that.
What was your name again?
I'd like to know how you assess the arrest. Is it a sense of hardness with a light explorer touch?
That's a really good question. I think it was it the IADR in 2014, Steve and Martha Steffens staged a Boston Tea Party with the Explorers and threw the Explorers into the Boston Harbor. And I have a collection of about 200 Explorers, and I'm going to do an art project with them. Yeah, so we use the Curio probe in my practice because, you know, Curiology for decades has been saying, throw your Explorer away. I want black from wall to wall on that lesion. Just like the old pathologists do teach us, we want well-circumscribed margins. I want a clean margin all the way around that lesion. Black all the way through with a ballpoint explorer or Curio probe should be hard. And I've been doing more x-rays than I used to do. I'm a less is more kind of guy, and you know, your failures stay with you. Some of my lesions that have kept growing with the silver fluoride only plagued me, you know. There's that girl, and she had 4 lesions and they weren't that big, and she kept coming back and she was perfect, and I got to put it on perfectly every time. Did it 4 times a year, and they just kept growing. No new lesions, they kept. So now I take more x-rays based on some of those failures.
Cool, thank you. Got one practical tip too. If you're using SDF in your practice, be sure if you're using it to don't use the plastic damages, or if you use a glass imperfect in your ultrasonic on your instruments, it should just be a micro brush, very small armamentarium. If you put it in your ultrasonic to clean your instruments, everything turns black. So, you were very, just please throw everything away and be careful, just don't stain. It works great. I've been using it in my office with great results. I think I have 1 tooth that ended in, and that was it. Everybody else did quiet and happy patients.
Cool, thanks. So one of the reasons we want you to keep your questions till the end is because we overlap. So if your questions aren't answered now, they might be answered later. So a little bit about myself. For those of you who don't know me, I'm Doug Young. I owe my poverty to John Featherstone. 1995, I was making a good living. I had a successful private practice, and I heard John's lecture on how I'm not treating the disease at all by my practice. And I said, well, is that ethical? Is that right? And in addition to hearing loss, I decided, okay, let's learn more about this. I spent the next 4 years getting my master's under him, and then ever since then, spreading the good word. So thanks, John, for making me poor. Again, this collaboration grew and grew, and where we're at now is these crazy guys up here are insane. I think Jeremy underestimated the number of emails that go each day. I think it's more like excess of 20. And you want to just trash them all, but you can't. They're just insane. They're like, on a Novi energy scale, where 10 is a Brian Novi, these guys are like 8.5. And that's pretty sad. Okay, a couple comments on Jeremy's talk. I wonder if the pH of the SDF, which is about 9 or 10-ish, is also having an antibacterial effect, as well as training the biofilm in the mouth to behave according to Marsh's theory. So that's something to keep in mind. He mentioned light curing to precipitate. That's great if you're going to use multiple applications and arrest the lesion first. As you will see with John's presentation later, there are instances where you may want to restore on the same day. So if you're going to restore on the same day, we recommend not to light cure because it'll turn, if you're using resin, it'll turn it black. So that's why my pitch right now is to use glass ionomer. So let me give you an overview of the strategy. Jeremy presented buku, high levels of evidence, randomized clinical trials, systematic reviews, meta-analysis. On the ADA Evidence-Based Dentistry website, you will learn more about that. If you use that philosophy, this is high levels of evidence, about equal to fluoride and sealants. So the material Jeremy presented is not low-level evidence. It's not like xylitol may or may not work, depending on what trial you read. How many trials do we have for Cambra? Probably just one, right, John? And that started in, the idea started in, I remember, in 1995 when I first got there, and it didn't get published to 2012. That's why you can't wait for another randomized clinical trial. We have to act now. Our patients need us now, and drilling teeth won't help. So when we get to the ethical question tomorrow, we have to figure out what are we going to do to change this. Okay, so science, science, science. We're going to present science now for glass ionomer, and I'm going to present high levels of evidence. We're going to present high levels of evidence for partial caries removal. Again, science, science, and science, individually. Then John Frisella is going to talk about combining these techniques in a way that doesn't compromise the science that we have just presented. And then he's going to talk to you about crazy things that we haven't yet had the science for that he has to do in his practice. And then Jason is going to teach us how to make money doing it. Okay, so let's start. I use glass ionomer as a chemical treatment for caries because there's no other restorative material that we have that has the same formula for remineralization. And this formula is represented in this paper by He and No. He uses electron probe microanalysis to prove that ions that flow back and forth between glass ionomer go back and forth is called ion exchange. And this mechanism causes a remineralized surface on this SEM. So what you're looking at is on the right side, I learned how to turn that. On the right side is glass ionomer, on the left side is enamel. And when you treat glass ionomer, what we're going to teach you how to use glass ionomer properly today is the first thing you do is pre-treat with polyacrylic acid. Polyacrylic acid will remove the smear layer and hopefully activate the surface. Activate the surface to me means not removing all the calcium and phosphate like acid etch does, phosphoric acid, but activating and loosening the molecules of calcium and phosphate. It also, in my mind, removes part of the carbonate. Carbonate is a defect in the crystal, and it makes the solubility more in acid. So by removing the carbonate, replacing it with calcium phosphate and fluoride, that's the formula for renin. And that's why when we scrub this with phosphoric acid to remove the smear layer for the SEM, you see that it dissolved the glass ionomer on the right, and it dissolved the enamel on the left, but there's a Sierra Nevada mountain range, or a Rocky Mountains in between the two that did not dissolve. And this has been reproduced by SEM. It's reproducible. So your eyes cannot lie, and that's why underneath every glass ionomer, I picture after about 2 months, and that's arbitrary, that I have this protected layer that's going to be there forever. It's just like fluorapatite. It's going to be there forever. The restoration is an acid-base reaction. It's not a polymer. There are no double bonds to degrade over time. That restoration is going to be there until someone takes it out. So that's why we use glass ionomer. A little more about my background. After being poor and started teaching, I also got shipped out to a long-term care hospital in San Francisco, Laguna Honda. And there we treated medically compromised patients that some of them were dying there. They're not going to get out. It's a long-term care hospital. And working with Alan Long in hospital dentistry, some of these patients are not healthy enough to go to the operating room. So what are they going to do? Suffer with dental caries. So we started using silver nitrate before SDF was clinically approved, FDA approved here. So let's see, SDF, yeah, SDF was approved. So Steve Duffin taught us how to use it, and we've been using it on special needs patients, patients where the waiting time for the operating room is 2 years, and patients that just aren't healthy enough for an extraction. And by using glass ionomer, and we're going to tell you the rest of the story later, we're getting great success. So we're going to share that with you today. This next slide is going to be quick. There are 3 important papers that show that glass ionomer and resin, as far as sealant material, are equally effective. This is a JADA paper, 2011. In 2012, a randomized clinical trial actually came out and said, if you measure the ability to inhibit caries disease, not retention, glass ionomer is actually superior to resin if you measure that. Okay, that's one randomized clinical trial. I promise to show you different levels of evidence. The highest levels of evidence above a systematic review are evidence-based clinical guidelines. Okay? And so this paper, and I think Brian got to work on this paper, is the most recent, hot off the presses, 2006 JADA paper that basically says sealants are effective and safe to prevent the arrest and progression of non-cavitated carious lesions compared to fluoride varnishes. And then it went on to say, basically, there's not enough research now to show that one is better than the other, which we knew. So, yes, Brian?
I just have to jump in here. Ed Hewlett was on this as well. And if you actually read the systematic review in JADA this month, it says, glass ionomer sealants confer an additional 63% caries inhibiting effect.
Repeat that again. It's being published when?
It's in JADA this month, August, this month.
Is that a correction of the paper?
It's not a correction of the paper, it's in the paper. It's not in the forest plot, but it says glass ionomer sealants confer an additional 63% caries incidence reduction. In addition to the preventive effect of the resin-based sealants.
And my apologies to you, Ed, I forgot. Anyway, so this is for clinicians that don't read systematic reviews, they're hard to interpret. This force plot stuff, we're going to show you them, but they're hard to interpret. So the evidence-based clinical guidelines by ADA are, when they do come out, few and far between, are powerful statements. They're people that are much smarter than us, looking over the data and putting it in plain English. And yeah, it's that thick like a phone book. And so what we need after these guidelines is someone to interpret them into plain English. And that's what we do here at meetings like this. This is another paper that just recently came out, another systematic review and meta-analysis that basically said, we conclude that there's moderate strength of evidence that and a positive association between glass ionomer cement and the prevention of carious lesions, only on the margins of occlusal proximal restorations in primary teeth. So basically what they're saying is, if you use GIC in a class 2, it works at preventing caries. So
In the adjacent to?
Say that again?
So it's saying it, well, if I put a class 2 GIC in one tooth on a child, it will help prevent caries on the proximal tooth.
Yeah, I have another slide for that one. Okay? So this talk about forest plots. This is another forest plot. And why are forest plots so important? If you learn how to read them, to me, it's a shortcut. You know, the paper might be this thick, but if you cut to the forest plot, it tells you everything you need to know. So in this particular case, I can't see with my glasses. That vertical line that you see should be the line of no effect. And if everything lines up on that line, basically it confirms a null hypothesis that there's no difference between resin and glass ionomer. However, if you are on the left side where that blue arrow is, that means that the review, systematic review favors glass ionomer. If it's on the right side, it favors resins. So I want to divert your attention to the bottom square where the blue arrow is. What that's basically saying is over 5 years, if you use glass ionomer, and another beauty of systematic reviews is it makes it more precise. By using statistical analysis called meta-analysis, it's a way to combine data of different clinical trials into a more precise statement, and that's represented in the diamond. So even though some of the studies touch the line, which means it's not statistically significant, the horizontal lines on these little clinical trials, but when you do the meta-analysis, it becomes statistically significant. So that's why it's more precise. And what this says, if the line of no effect is 1, because it's using either odds ratio or a risk ratio, and if the numerator and the denominator are the same, they're going to equal 1. So if it equals 1, it means there's no difference. Okay? But if it's less than 1 in this case, it favors glass ionomer. And if you look at line that up, it's basically saying the left tail of the diamond approaches 0.1. And basically, if you take 1 minus the risk ratio, it's basically saying it's a 0.9 or 9 times greater, better than resin at the very best. On the right side of the diamond, it says it's touching the line. That means at the very worst, it's equivalent to resin. And that's a very powerful statement. Because one of the questions was, do I just put silver diamine fluoride instead of sealants on occlusals? And my answer is, yeah, if you're going to put resin, I would treat it with silver diamine fluoride and then not replace the resin. But if you're using glass ionomer, there's absolutely no disadvantage in putting glass ionomer on over the top of SDF, which John will cover in his talk, because we're not prepping the tooth. And that's the key. With resin, you have a question of how does phosphoric acid etch aprismatic enamel? We know that doesn't happen. So what is the effect of resin placed on aprismatic enamel? And then if you remove the aprismatic enamel, now you're invasive. So depending upon the patient, there's different strategies that you may want to use, and we're presenting one side of the story today for a reason. This next slide was a study that you just talked about, where by placing, this is incredible, because you place SDF on the occlusal, glass ionomer sealant, on the occlusal. It not only protects the occlusal, it protects the proximal surface, and there's no glass ionomer there. And so one of the proposed theories is charging and recharging of fluoride that occurs, and time releases after that will protect an adjacent surface. Okay, and you're hearing the same story told by Jeremy, where silver diamine fluoride placed on a lesion can protect areas that weren't coated with the silver diamine fluoride. So there's clearly some time release mechanism going on here that affects adjacent teeth. Okay, so moving on. What I'm going to move on to now is partial caries removal. Okay, another area where we have high levels of evidence. Okay, if you put it like I left decay in the tooth, that sounds very negative, right? That sounds like malpractice. But if you say Dr. Young practices conservative caries removal, that sounds like I'm pretty smart. But it's the same thing. We're going to leave infected dentin on a tooth that's vital and asymptomatic, a healthy tooth. It's not bothering the patient, rather than mechanically exposing the pulp for no reason. So what's the level of evidence for that? I told you the highest level of evidence is a systematic review. Well, a critical review is another review of the systematic review that basically puts it in plain English. And if you're able to read what I underlined there, this is a Van Thompson paper, I forgot the year, gosh, 2008. 2008, and I almost have it memorized. There's substantial evidence that removing all vestiges of infected dentin from lesions approaching the pulp is not required for caries management. So a critical review summarizing several systematic reviews and randomized clinical trials, basically saying substantial evidence. Most papers say more research is needed, right? This is substantial evidence, okay? And this isn't the forest plot for that particular systematic review, but it's an interesting one. So what it basically says is, if you look at pulp exposure, the top one, look how far away from it is from the line of no effect. And someone smarter than me, I think this is a typo, because the line of no effect should be 1 in a ratio. Is that right, John? So somehow it's labeled 0. I don't know if it's a typo, but...
No, it's double zero, so I think it's 0 going both directions.
It should be 1.
It should be 1, I think.
Anyway, odds ratio could be 0 or 1, depending on what statistics they use.
Unless they do
There's a fraction below
the
that.
difference of ratio is equal to 0 if without effect. But the odd ratio and relative race must be 1. If you do a difference, then you do it.
This is not a mean difference, so there should be a ratio. This is the odds ratio. It says on the top. It says not a mean difference. Mean difference should be 0, but odds ratio should be 1. But regardless, that's not important. What it's showing is we're taking multiple randomized clinical trials, some of which are not statistically significant, and we're making it very statistically significant, and it's very far away from the line of no effect. So pulp exposure, and that's a no-brainer. If you do incomplete caries removal, you don't chase decay, you're not going to expose the pulp. That's a no-brainer. What about postoperative pain? Well, that's a no-brainer too. If you're not approaching the pulp getting too close, you're going to cause less postoperative pain. The bottom one is the most important because most operative dentists chase decay because they think somehow it affects the restoration. It makes it less supportive. And clearly, if we're remineralizing underneath and making it stronger and harder than it was before, that doesn't pan out in the systematic review. It's right on the line. There's no difference. There's no difference to the restoration whether you do complete or partial caries removal. So that's the take-home message because the top two are no-brainers. Another paper on this, from the ADA, basically talking about caries classification. Throughout this next day and a half, we're going to be using different terms. And I'm hoping that we start using more precise terminology. I don't really think the term caries by itself gives us very much information. We don't know if we're talking about the disease or are we talking about the lesion. If we're talking about the lesion, we need to be very specific because our treatments are based on the lesion stage. And so this paper, if you haven't seen it, is very important because it not only defines different stages for different areas of the tooth, but it also has these columns, green, yellow, orange, and red. And basically what that's insinuating is when it's cavitated. So let's look at one of the rows. If you look at this row, it says infected dentin. So an ICDOS 0, 1, and 2 are unlikely to have infected dentin. Same thing for a E1, E2, and a D1 lesion on a radiograph. It's unlikely, based on the science that we have now, to be cavitated. And the facial lingual lesions, we don't need a radiograph. We don't need an ICDOS code because we can see the lesion. If you can see the lesion, we're trying to determine whether the tooth is cavitated. And if you can see it, you can tell if it's cavitated. If you see dentin, it's cavitated. I don't need an x-ray. I don't need an IC-Vasco. Okay? So what's the significance of cavitation? Well, it's obvious. If the tooth is fully cavitated to the dentin, bacteria would just walk right in. If the enamel is present, the diffusion channels in the enamel are much too small for a physical size of the bacteria to fit through. So the enamel acts as a protective screen that keeps bacteria out. And I'm surprised how many dentists that drill teeth don't know that, because they're drilling E1 lesions, E2 lesions.
Can I hijack for 1 second?
Hijack.
The answer to your question is...
Are you speaking in the mic? All right.
Good.
The answer to your question, Doug, is the state licensing exams in every state confuses everybody from day one. You don't know what to do. We're telling you not to do something where the state is licensing you and telling you to do something. So how can we ever get out of the inertia that we're in until we stop this nonsense of the surgical paradigm coming from the educational institutions supporting what the states are telling these students erroneously to do?
Good lead-in, because we have an attorney here, and we're going to defer that to day 2. We're going to talk about standard of care. But to answer your question is, they should not dictate care of our patients. Our care of our patients should be based on evidence-based dentistry. The science, the skill of the clinician, and if I'm skilled in glass ionomer, I choose the right to choose, and then the wants and needs of your patient. You have to discuss this, give them options, and let them choose. That's the core of evidence-based dentistry. So that's what we're promoting to do in this next 2 days. Okay, so getting on with terminology, you gotta know when to stop drilling. And one of the things that you can see in this middle picture is that's what we all would agree is gross decay. Many of which would say, okay, this treatment plan, a root canal. But if the tooth is vital and asymptomatic, I propose to you that we should just clean the perimeter of the lesion, and 2 millimeters is arbitrary. I just teach that to our students so they know from the cavo margin, if you go 1 millimeter, you're not going to hurt it into the axial wall, you're not going to hurt anything. If you go 2, okay, it's getting a little deep, but you're still not going to hit the pole. Okay, so you're in a safe zone for a student, a beginning student. If you clean that, pristine clean, I don't care if you're using resin, amalgam, or glass ionomer, you're going to get a clean bond and seal to that tooth. And systematic reviews and randomized clinical trials show that if you seal the margins of a restoration, even if you leave infected dentin into the tooth, the lesion will not progress. If fermentable carbohydrates can't reach the bacteria, there's no acid to be produced. No acid means no demin. No demineralization, no treatment. Okay? So our battle is won by simply sealing it out. So if you, again, look at the overall message we're sending is SDF alone, good, kills and arrests. Incomplete caries removal, followed by a sealed restoration, will stop, arrest the lesion. So now we have 2 tools in our toolkit that have high levels of evidence that says we can do better. Okay? And now what I'm going to propose to you now is if we use glass ionomer, man, we really got a good thing because of that internal remineralization, the concept of a long-term acid-base reaction that promotes the release of surface fluoride charging and surface fluoride release. I do want to warn you, if you practice incomplete caries removal or this conservative type of removal, you're going to see a radiolucency under your filling. And a lot of people, if the patient goes down the block, the first thing the dentist does, oh, you got recurrent decay, we have to replace that. Okay? We're going to, replace that. So I need you to think, there's 3 things that can be: recurrent decay due to an open margin or a failed restoration. It could be very rarely now, but a non-radiolucent bonding agent or some kind of liner. And the 3rd thing it can be is affected dentin or infected dentin. It could be remin, demin, infected dentin. You can't tell from a radiograph. Okay?
And also, the way the cone is angled, can make your progression or
Look worse.
regression look worse or better.
So the bottom line is, do what we do every day. Check the margin.
Hi, I'm trying to simulate again the strength of glass ionomer in an unscientific test. What we did is a large crown type preparation and made a crown glass ionomer. And we stored it in saliva for 2 weeks. And now we're trying to break it. Still in the tooth. Okay. The stone broke. Glass ionomer is still in the tooth. You want to get a close-up? All the margins are intact. There's a few chips, granted.
Have a time.
Okay, look, we got the tooth broke in half. But I want you to notice I was hitting the glass ionomer straight up on the occlusal where there's no enamel, and it caused the whole tooth to split in half. But the glass ionomer is still in the tooth. That's about as hard as I would hit a small nail. The bottom of the root is shattering. And there we go. Again, we have the tooth splitting in half, but the glass ionomer is still in the tooth.
So this is just a quick one about combining the two pieces that Doug just explained, glass ionomer and partial caries removal. This, probably all of you guys have heard, is called ART, Atraumatic Restorative Technique. Other groups like to call it other things. How well does it work? Do we have clinical trials on it? Well, it turns out we do. And so this is a smattering of evidence. They didn't do the force plot, but it's a meta-analysis. And the point is that at year one, 95% of the restorations were still in there. So this is all hand instruments, leaving caries towards the pulpal, putting a glass ionomer in place. Year two, 93%. Now, year three, there's only 2 studies instead of the 7, but it dropped quite a bit down to 66%. And that's for a one surface filling, so usually an occlusal. So really high, and then it starts to decrease with time. What about multiple surfaces, 2, 3, 4 surfaces on tooth? We're getting much lower numbers in terms of the clinical success of scoop and fill glass ionomer. Now, if we were to use what Doug talked about in terms of using a nice burr for getting really clean margins past the DEJ, maybe it's higher. But we wanted to put together something that could be done in rural Alaska, in the areas that John serves, that he's going to be talking about. And so that's why we've been talking about glass ionomer. That's why we've been talking about partial caries excavation in relevance to silver fluoride, which I'm going to interrupt these guys up here so that we can now talk smart. Dr. John.
I'm going to beat in.
Actually,
for 1 minute.
yeah, let's let Doug step in for a minute. We just discussed something that
we were adjusting on the fly. One of the reasons is one of my videos didn't work on his computer. So I wanted to talk to you a little bit about some misconceptions of glass ionomer. People say glass ionomer cannot be used under compression and that it's soluble, it dissolves away. And I can tell you by almost a decade, Alan Long and I have been using this in the operating room, probably over a decade now, but 15 years or more. And we first started using it because we had 3 hours and the patient could have a mouth that's just devastated. We don't have time to do composite or mouth. So we started putting bands on teeth and filling them up with glass ionomer. And if you do the procedure properly, John will go over the step-by-steps on some of my slides that we had for you. If you follow those steps, we found something incredible. Those 2 myths are exactly myths, okay? They don't dissolve, they're not soluble unless you subject them to high acid. If you have a GERD patient, bulimia, drink Coca-Cola every day, all day long, yeah, you're gonna get some surface wearing. But no more than like the streets and like cement on the sidewalk. If it's a high traffic back east where the sidewalks are old, you can tell the sidewalks are worn, okay? But it's not gonna leak at the margin. Those margins you rarely see are any staining or deep degradation at the margins. And if you don't believe me, look for yourself. Okay, the second test we did was occlusion. Why aren't these teeth breaking? These patients are special needs patients or medically competent, and we're putting a band on with basically making a glass ionomer crown.
This presentation there. So we are trying to disseminate. My role really is to just share a couple of interesting clinical cases. You know, they would just be interesting clinical cases with an N of 1, which I admit. This is not science. But when you use important clinical cases embedded in this cocoon of science and evidence, it brings life to what we're talking about. And this is a moving target, and so again, I get a chance to just share a couple of cases. So what Jeremy has actually called the kitchen smart. It's a little girl named Claire. 4 years ago, I got a phone call from my practice in Kaiser, Oregon, not Kaiser Permanente, the city Kaiser, Oregon, just south of Portland. A mom from Utah saying, I have a 11-month-old daughter who's scheduled to go to the OR to have 11 months, scheduled to go to the OR for 4 stainless steel crowns on her front teeth, and I just don't feel good about that. And you know, I found you on the internet, and do you think you can do anything? And I said, maybe. Do you have some x-rays or something? She goes, no, we'll get in the car right now, and we'll drive from Oregon, from Utah to Oregon, if you can see her tomorrow. So this mom arrived the next day, and sure enough, we have a 11-year-old child with classic ECC and anterior teeth. And maybe 10 years ago, I would be thinking about going to the OR with this child because I didn't know as much as I know today about the risks of general anesthesia or the risks of sedation, etc. So fortunately, I knew how to use silver compounds. And so we treated Claire, and we arrested all of her lesions. And they went back to Utah. And then we stayed in touch. She came back in 6 months, and we examined her again. No new lesions, no progression on those lesions. The dentist in Utah had taken radiographs, no progression, and then they vanished again. About 6 months ago, Claire's mom calls me and says, we now live in Bellingham, Washington. Claire is 4.5. She's getting ready to go to school. If you look at the large image of her, you can tell that there's some dark staining in her anterior teeth, okay? Classic silver arrested lesions. And mom said, we're a little worried that Claire might be made fun of at school. Is there anything you can do? So the expert on managing anterior aesthetic cases is this guy, John Frischella. And so I contacted John and talked about how he would handle that. And John said, bring her to Bend. So we arranged for Mom and Claire to drive from Bellingham, Washington to Bend, Oregon, where my son has a vacation house, and we treated Claire in the kitchen. Okay, that lower right image, that's the kitchen. And since this group of colleagues has been emailing and talking, I talked to Jeremy, and I told Jeremy about this case that was going to happen. And I've been trying to get him to come watch John. Jeremy came from San Francisco to Central Oregon to meet Claire and her mom. And he was there. And I videoed the whole thing. And if you go to MMC Library, under patient testimonials, you'll find Claire. And you can watch John treating Claire with a resin-modified glass ionomer opaquer to cover up her discolored teeth. You can see an interview that I conducted with Claire's mom 4 years ago that I saved, where the mother articulated her concerns about the use of general anesthesia with her child. By the way, this mother is a molecular biologist and a patent attorney. Okay? Was she worried about the few stains on her little girl's front teeth? No, she was worried about her neurons. She was worried about her child dying, perhaps, in a sedation. So this is an amazing success story. Claire, it's on MMC Library. All of us are involved. It's a great story. And I've been doing this for 10 years. Okay, I heard about it about the same time John did. And got my smuggled SDF from Japan, and I thank everybody who did the work to bring it to America so that we're not in our closets doing this. Everybody in America can do this now. It works, and I applaud them for their efforts. So Claire is one of our huge success stories. Another amazing story, I had a patient named Robert who was a stroke patient. I began treating him in 2006. Robert never brushed his teeth. He was unable to brush his teeth. So he's a classic, significantly disabled patient. He had to be sedated even to bring into the dental office. We bring him in every 3 months. We get out the ultrasonic, we blast away, we have blood flying everywhere. We try to get down to tooth structure. I would always find new decay and acute gingivitis. We did this for about 3 years, just trying to maintain his oral health. Unfortunately, he just lived a couple of blocks away. When I got really comfortable and I started using SDF in children, and I started thinking about using it in selective adult cases, in the case of Robert, I said, you know what? I wonder if we just paint all of his teeth with this stuff. I wonder what would happen. Could we reduce the number of new lesions that he was having and reduce his gingivitis? And so we did that. We painted SDF and fluoride varnish on all of his teeth with consent, and I said, I don't know, all of his teeth might turn black. And he's hard to communicate. The wife said, we don't care. Okay, this is an image that I took 3 months later. And as soon as Robert was in the chair and he opened his mouth, I looked and I said, get my camera. And then I said, who's brushing his teeth? The wife was there, she goes, nobody. Then the next thing I said was, did you take the soda pop away from him? No. You mean there's been no change in the past 3 months? Now look at that now. There's no plaque on his teeth. He has no gingivitis. And there had been no change in his life except we put SDF and fluoride varnish on his teeth 3 months earlier. So we've now been following Robert. And I went and did an interview with him, and that interview, by the way, lives on mmclibrary.com, okay, under patient testimonials. Robert, you can see it's a home video. I'm sitting on his couch, and he's much better medically, but he talks about his experience with what we call the medical management of caries. Now, Robert lost a few of his lower anteriors because they had 90% bone loss before we started. And you can see the dark silver in the cementum, obviously, okay? So it does stain cementum, it stains active decay. What's important here is that Robert has had not one new caries lesion since we treated. And he has no gingivitis. We continue to follow Robert every 3 months because he's such a high-need patient, but such an interesting case study. So, this example of our ability to treat a young child, to avoid going to the hospital, stop their disease atraumatically, and in this case, in a special needs adult patient, clearly control the pathogenic factors of their oral health problems on both the caries and periodontal side using this product. And I'm so grateful that people like Jeremy are here to do the science to tell us how this works. I'm not sure whose case this is.
Yeah, this is my case. Okay, I'm going to run through this real fast in the spirit of trying to keep this going. Okay, so I'm a pediatric dentist. I don't treat adults. I was in Fossil, Oregon. This guy walked in. He's a big brute of a guy. And he wanted some teeth out. And I said, all right. He said, I want no drills and I want no needles after the teeth are taken out. And I really don't want any care at all. He had a can of Coke in his hand and he had a lifesaver in his mouth. And this is what we had. For teeth that needed to be extracted. You can see the abscesses there. And then I spoke with him and I said, hey, can I just paint your teeth with some silver? And it'll make them feel better. You have toothaches in the other teeth? Yeah, they're all sensitive, but I don't want anything, Doc. And I said, well, it might not taste good. That's what they always do. You can leave the lifesaver in your mouth, keep the Coke in your hand, take a swallow of the Coke. I don't care what to do. I'm just going to paint your teeth. Can I do it? Why? Because of Steve. The case and Robert, the case that Steve just showed you. It inspired me to do this. And he came back. He came back a month later and he said, gosh, Doc, this is great. We'll put some more of that on there. And I said, yeah. So I put some more on. And then he said, well, you got anything else going that you can help me with? And I said, yes, I can. Look at the gingiva. Look at the difference here. I put glass armor in. And everywhere. And I just put as much glass armor as I could, even if you didn't need it, everywhere. And I'm going to make this as a statement. I no longer consider glass armor as just a restorative. I consider it medicine. And I certainly consider silver diamond flare as a medicine. And, forgive me, many of you are brilliant scientists here. I'm a clinician, okay? I'm just going to make this as a statement. This is my clinical experience. The more silver diamond fluoride and glass ionomer I put in anybody's mouth, the less oral bacterial infection they have. And caries is a very small word. I don't like to use the word. You have your own lexicon. I honor that. I respect that. I'm going to use OB, oral bacterial infection. And I am Obi-Wan Kenobi, and I'm going to knock it out. Because I got two things that can do it. They're medicine, they're medicinal, they're also restorative. It worked on this guy, and it took him 3 years. It took me 3 months. 3 months, I got him into shape. He drove in the other day, and he just wanted to say hi. And he says, that stuff tastes like shit. But my mouth has never felt better. And he still had the can of Coke in his hand, and he had a lifesaver in his mouth. And I never lectured him about diet. I never gave him a toothbrush. I never said anything. I said, anytime you need me, man, I'm here for you. He said, Doc, I appreciate that. He high-fived me, and out the door he went.
So I'm just going to briefly show some pictures to you guys to show about aesthetics. This is from, I believe, Alan Wong and Oh, you showed it?
So I want to leave time for Jason, so I'm going to go really, really quick. These are cases we did, Alan Long and I and the crew of students did in Fiji. Where's the beginning? Here it is. And we did 1,100 surfaces of SDF. And I only caught them once, a student using an injection. So
practically no anesthesia. These are grossly cavitated lesions, obviously, and Yaya, to answer your question, the way you can do this cosmetically is simply follow the 3 steps separately that we described earlier. That's called the ideal treatment. So what we did here was SDF, then we cleaned the margins, and then we bonded the glass ionomer in as per manufacturer's instructions. If you notice, this has semi-clean margins, this one does not. So in the final case, you could argue that these are almost composite-like, but this one has a little dark halo because we didn't do the clean margins as well in that case. Okay, so again, pardon me? No, this is conventional glass ionomer. The secret to getting an aesthetic result is respecting the moisture as the glass ionomer is setting. You cannot let the surface dry, especially when you're polishing. You gotta have an assistant spraying water on it, okay, when you're polishing it. I use the Ultradent Jiffy kit to polish it down, to contour. And it comes out composite-like. And our power went out, so we didn't have a mixer. And so we did some hand mixing. It wasn't very aesthetic, but it worked. Okay.
This I think I'm going to skip so that Jason can talk about the economics. But as you see, there's a lot of questions where first I talked to you guys about using silver fluoride only. And then we talked about using glass ionomer. And then we talked about using them together, the partial caries excavation. So going forward, I hope that over the next 2 days we can meet in the hallways, and we'll be up in the bar tonight if anybody wants to talk to us about this stuff, about how best to serve our patients by combining these materials. Do we always use silver fluoride? Do we always need to cover? Do we ever need to cover? All of those questions. How can we get to 100% with cost effectiveness, with long-term effectiveness, with not needing to harm the patients? So just for some pretty pictures, we've been taking some of the smart treated teeth that have now exfoliated or extracted for orthodontic purposes to the advanced light source over at Berkeley, where things look like this. There's wires everywhere. It's the most advanced laboratory I've ever been to, and looking at them and just asking the question of how well the silver is penetrating. Silver diamine fluoride, glass ionomer cement, is it staying in there at all? And so what we're seeing is that not only is it staying in there, it's going well over 1 millimeter into the lesion, almost all the way down to the pulp. And we're actually getting, so this is the tooth, the cavities to the upper left. There's a little white and red stuff here that you can see. We go back and forth there. You can see that that's the silver in the lesion underneath. So we're basically just trying to start documenting this combination of partial caries excavation, silver fluoride, glass ionomer cement. And they're pretty pictures, we can look more at it later. But what you can see even clinically is that silver spreads underneath the glass ionomer. And so, God forbid, if it popped out, you not only have the increased strength of the tooth, but you also have silver in there. And the coolest part for me, I think, is that if you look down here and throughout here, we're actually getting silver wires forming in the tooth. So we're getting solid silver forming in the lesions. So it just makes us scratch our head and think, is this really like the best thing that we can do? Because it seems pretty darn good. Is there any way we can continue to improve it? So I hope you guys are involved in that conversation. And to end that part, I just think this looks cool. So. Right.
Can I just interrupt for just one quick Just 1 second. Okay, if you ever run out of power, like Doug did, and you're in teaching, I've invented the bicycle triturator and the cordless jigsaw triturator, and I can show that to you later if you want. So come to the bar. At the bar. Okay, so let's wind it up here. I feel like I'm the 4th guy in the lineup here hitting the home run because we put everyone on base. Exactly. So who am I? My name is Jason Hirsch. I'm a private practice pediatric dentist down in Royal Palm Beach, Florida. It's a nice enclave just west of West Palm Beach. It's a very wealthy area. I've been a pediatric dentist for almost 15 years now, and I did pediatric dentistry for many years the way that pediatric dentists are taught. And
You know, I kind of liken it to taking a car and driving it into a wall and then putting it in reverse and driving back into the wall again. You know, and in my nature, I just can't keep doing that. So I started saying to myself, I have to get better at what I'm doing. And so that's kind of how I got to where I am here. But I kind of give you another perspective of things because, you know, John's in the wilderness, Steve's kind of in the wilderness, Jeremy's in an academic institution, Doug is kind of in both worlds. And I'm just a private practitioner surrounded by wealthy people with kids who get tooth decay. So I said to myself, in a world of sameness, the only way I'm going to become better, not only as a doctor, but to make a living doing this and uphold all the things of why I went to school and do all those things, I've got to be different. Because what's happening is, and everyone will know this, all the students that graduate dental school are congregating in the metro centers. And we're cannibalizing ourselves. So when a patient goes out into the world, they're part of this game called, I call it patient ping pong. And a parent will have a child with tooth decay, wherever it may be, in the front and the back, a combination, and they'll go to a pediatric dentist, and they'll get this long treatment plan, and it's like $3,000 to $5,000. And the mom and the dad will probably go home and scratch their heads and go, wow, general anesthesia, in-office IV sedation for baby teeth? Really? So then they go to the next pediatric dentist, and they get the same conversation. So now the ball went over the net and it got hit back to the other side. And they go home and they scratch their heads and go, wow, these two people now saying the same thing. So what can we do? Because we don't want this. And so after realizing this, because I was either the first guy or the second guy, I said, you know, I've got to get better. I've got to learn what I'm doing. And so I started studying caries. Shocker. And so through that process of understanding caries, I found these guys, and I was at a conference, an AAPP-sponsored conference in Chicago on caries, and actually was just at a ADA-sponsored conference in New York last week on caries. And I feel like when I'm in these rooms, I'm just in inertia. I'm just like in this spinning vortex of the same stuff over and over again. And that's why the silver diamond fluoride and this SMART technique is a way out of this vortex. And it's also out of this vortex economically. Because when that parent who now plays ping pong and has gone from one side of the net to the other side of the net finds me, I'm actually the guy who smashes the ball and ends the point. Because I've got these techniques that work, because not only are they, you know, I've heard some reports in the media that this is the cool, hip, new medicine in dentistry. This isn't cool, this isn't hip, this isn't new. This is understanding caries, the disease, understanding what cavities are, the end result of the disease, and understanding as a doctor how you can play into both of those worlds with this cool, hip, new medicine, okay? And also fulfill the principles that we're all supposed to be guided by, because if we look at the way that things are set up now, the Department of Health and Human Services has this thing called the triple aim. Who knows what that is in the room? All right, so the triple aim, for those who don't, is to improve the population's health. So that could be the entire population, that could be your population, and if we stick to that it's our population, then the entire population will become healthier. We're supposed to improve the experience of the patient in that setup, and we're supposed to reduce the cost. Well, when I go back and I look at what I was taught in pediatric dentistry, I think it's the opposite of the triple aim. So there's the inertia again. So SMART to me, which is silver modified atraumatic restorative technique. Okay, it's the layering of evidence-based dentistry, one on top of another, to come up with a way to satisfy the triple aim and actually do something that's now attacking the disease process at the process's roots and treating the symptoms at the same time. It's the culmination of everything that we're trying to be as dentists or doctors. And on my door now, I don't write pediatric dentistry on my door. My door says pediatric dental medicine, because I'm trying to sophisticate what we're supposed to do. I'm not a bondodontist, okay? I'm a pediatric dental medicine provider. And when people come to me with a problem, I have a solution that's not only for the cavities, I have a solution for the caries. And so, let's talk about the economics a little bit now. So, there's another Christensen in dentistry. Sort of. Well, right, there's three Christensens in dentistry, right? We know the two, Rella's in the room, we know her husband Gordon, but there's this other guy who's at Harvard, and he wrote this book, The Innovator's Prescription. Now, he's not a dentist, he's an economist, but he's also guiding us, both medicine and dentistry, to fulfill these promises that we have to our patients, to get them healthier, but to do it correctly and to do it economically correct. And so, you know, when I found out about SDF, I realized that this was a prevention and a treatment in one product, and we really don't have too many of those in dentistry. So I was like, wow, this is great. And when I started meeting these guys online, it was almost like an online dating site. We met there, and it's gone from a few emails a day to my wife saying, are you emailing these guys again? So, I just think this silver modified atraumatic restorative technique can make our practices grow. Utilization rates are horrible. Pediatric utilization rates are at 50% with paid for benefits. 1 out of 2 kids, they have a voucher to show up, whether their employer gave mom or dad who worked as the employee a voucher through these PPO benefits, or a Medicaid system where the government gave people these vouchers, whatever it may be. 1 out of 2 kids with a paid for benefit doesn't even show up for an exam. Why? And so introspection is also part of this problem. The professional organizations don't want to introspectively look at why patients don't even want to come to our offices. And that was another reason why I thought, hey, if I adopt this philosophy, this medical management of care, is this idea of smart technique, I may be able to get people off the fence that don't want to go. Because when you look at the reasons that are cited as to why people don't go to the dentist and why they don't bring their children to the dentist, there's 2 common themes. One is cost, it's too expensive, and the second is there's fear and pain involved. So if you've got a prevention and treatment in one product and in one way to do it, you're going to lower the cost and you're going to do it atraumatically. You're going to solve the 2 dilemmas as to why people don't come to the office. And if you think about it even on a more economic level, even deeper than that, if 50% of the children aren't coming and only 37% of the adults are showing up, well, what happens if they all of a sudden do show up, even in small increments? Are we prepared to handle with the old fancy, very time-consuming, technique-sensitive procedures that we do? Are we able to handle this overload of patients? I don't think so. So this only enhances our ability to roll out more effective care more frequently so we can start combating this problem. Because if these people do get off the fence now, because there has been some media reports and parents are finding out about SDF and SMART, if they start coming to our office asking for these techniques, or if their children are good candidates for these techniques, 1, do we even know what we're doing? That's why we're here. 2, can we even do it? So I think it's really important. We're at a really big inflection point in history of dentistry. If we want to get rid of this access to care problem, again, this is another inertia problem. I've been hearing this for 15 years, access to care. What is it? To me, it seems like it's patient ping pong. It's not access to care. And so, look, here's another good line that I thought of. Throughout history, dentistry has sought an alternative to drill and fill. But the economics of practice keeps this from happening. And I think that's the real reality. And so, silver diamond fluoride and smart technique, which is silver modified atraumatic restorative technique can bridge this gap. It can make it work because it's scalable, it's quick, it's efficient, it's effective, and that's what I've taken my practice to. So I'm in this suburban, enclave of wealthy people, and I've put this into place, and I've been as successful, if not more successful than ever. And there's no reason that you shouldn't adopt this. It doesn't have to be all the time. I'm an extremist kind of, if I do something, I take it to the full. So maybe I'm out on the extreme and I'm doing this to everyone. Maybe you just have to do this to some and start chipping away at this access to care problem that I keep hearing about. But I know as a public health specialist as well, I'll tell you my background in education. So I'm a chemist. I have a master's in public health that I did before dental school. Also a dentist and a pediatric dentist. So I understand something about public health as well. And public health is telling us that we've got to do more of these procedures if we're going to chip away at this problem. And so DentaQuest is nice enough to sponsor this. I'll wind it up real quick. DentaQuest has been really nice in sponsoring this, and DentaQuest is doing a really good job of trying to get SDF implemented into this paradigm of economics. And insurance companies will have to reimburse for these novel procedures to satisfy consumer demand. I have a Facebook page called SDF Action, and prior to the New York Times article that came out, there was a few people that chimed in on there. As soon as that article came out, I think 10,000 people liked the page. And now it's almost like 1-800-DENTIST, this page of mine. I get people messaging me, my daughter's going in for general anesthesia, do you know a practitioner here who can do this? Will you look at x-rays? This is a real economic thing. If you all want to embrace this, it's Cambra, it's sophistication. Cambra is sophistication of dentistry, right?
Right.
And this is sophistication of dentistry. Because this is layers of evidence upon evidence upon evidence in one simple little procedure. And so, the last thing I'll leave you with, there's been this consumer shift because of the Affordable Care Act. It's called cost shifting. And if the benefits that the employer pays for, if one of the benefits of SDF application were smart is not one of these benefits, it gets shifted to the parent, this cost shift. And so it's a way also for us to, in the private practice world, take these non-covered services and increase our bottom lines. They don't have to be expensive to the parent, but if you do a scale of this, you can chip away little by little by little. Over the years, you're going to gain more economic freedom from doing this. And so if we can get the insurance companies to get on board, great. If not, we have these non-covered services that we can bring the cost down for people. And that's what I've been doing, and I've never been more successful in practice. So I'll leave it at this. Anyone, because we're running out of time, if anyone wants to buy a bottle of wine, I can teach you how to do this in your practice real simple.
And I am going to leave you with the Jackson story. If you have to leave, you may, but I assure you, you want to hear this story. Jackson is 3 years old. He went to a pediatric dentist in 2014. These are the radiographs that were taken. Lesions were identified on the distal of L and S, but carefully. Okay, he was scheduled for restorations on L and S with sedation. These are the sedation drugs that were recommended. Hydroxyzine, demerol, chloral hydrate, nitrous oxide. He was going to be in a papoose board with local anesthetic. This is the typical sedation restorative case that was going to take place. Once again, I want to go over the drugs. Demerol, chloral hydrate, hydroxyzine, nitrous oxide, local anesthetic. In order to do this, Okay, that wasn't done, but that's an example of restorative dentistry. So I want to challenge you, why should we not do this? Well, here's a case of a 3-year-old child at the same time, 2014, that went to a general dentist's office to have restorations placed with the exact same drugs and who passed away. You might be aware of the child in Texas who passed away in a dental office during sedation in July, and the child in California who passed away in a dental office during sedation for dental restorative care. Silver medicine, silver diamine fluoride, represents an alternative approach to the surgical approach to care that requires sedation and general anesthesia. So we took Jackson to the dentist. We applied SDF to those lesions, or not so much lesions, that you saw earlier. There's Jackson with his mother and his brother. Here's Jackson with his mother applying SDF using Jason's technique of floss with the grandmother. So here's again, SDF applied intraproximally using a flossing technique. Here's Jackson with his mother, happy camper, no dental office. These x-rays were taken about 3 weeks ago. Look carefully at the lesions on L and S. They have not progressed. If anything, they have remineralized. By the way, Jackson is my grandson. This is not third world care. This is care for everyone.